Let's get straight to work. The mission today is, well, it's crystal clear. This is eye-healed MRCS revision deep dive covering thoracic anatomy, embryology, and clinical correlations. No wasted time, no fluff.
Exactly. We know you, the surgical resident, are incredibly busy preparing for the MRCS. So we're bypassing the small talk and getting right to the core material you actually need to pass.
Right. If you want to maximize your revision efficiency, you are exactly where you need to be. Hit follow right now on whatever app you're using to hear more revision content from us, and please rate the show if you learned something valuable today.
And we really mean it about efficiency. To cover this massive amount of ground quickly, we're going to run this deep dive using a targeted question and explanation format. We'll pose the highest yield MRCS anatomy questions and then break down the spatial reasoning required to understand them.
Yeah, but before we jump into the first question, head directly over to www.medsyncltd.com to get your surgical simulation kit. It includes a top-tier suturing kit and microsurgery instruments. It is an absolute must-have for your prep.
Absolutely essential.
Okay, let's dive right into Section 1, embryology and congenital anomalies. Here's our first major question. How do the embryonic aortic arches develop? And why does this dictate the famously asymmetrical anatomy of the recurrent laryngeal nerves?
So we can actually start unpacking this by looking at the perfectly symmetrical embryonic structure. In the early embryo, the truncus arteriosus gives off 6 pairs of arches that curve symmetrically around the pharynx.
Right, but to get to the adult anatomy, several of these just have to disappear.
Exactly. Specifically, the first, second, and fifth arches vanish completely. That leaves us with just the third, fourth, and sixth.
Which map out perfectly. The third arch remains as the carotid artery, the fourth arch becomes the subclavian artery on the right side, and the aortic arch on the left side.
And finally, the sixth arch becomes the right and left pulmonary arteries, and on the left side, it continues as the ductus arteriosus.
That structural shift is exactly what sets up the clinical trap regarding those nerves. I mean, think about how wild this is from a design perspective.
It really is. As the neck elongates during human development and those lower arches get pulled down into the chest, the recurrent laryngeal nerves have to navigate this shifting landscape. It's all about what the nerves hook around.
Because the fifth and sixth arches disappear entirely on the right side.
The right recurrent laryngeal nerve slides up and hooks around the lowest remaining structure.
Right. And that structure is the fourth arch, which we just established becomes the right subclavian artery.
But the left side tells a completely different story. On the left side, the sixth arch persists. It forms the ductus arteriosus, which eventually becomes the fibrous ligamentum arteriosum in the adult.
So the left recurrent laryngeal nerve remains hooked much lower down in the chest, right around that sixth arch structure, situated beneath the aortic arch.
It's an evolutionary hangover that leaves the left nerve highly vulnerable during thoracic surgery, while the right nerve is more at risk during neck operations.
Precisely. Let's move to our next question in this section. What are the key features of fetal circulation, and what are the precise physiological changes that happen at birth?
I can map out the fetal pathway. To understand fetal circulation, you have to follow the highly oxygenated blood starting from the placenta. It travels along the single umbilical vein.
Now, instead of passing through the liver capillary bed, most of this blood completely bypasses the liver via a critical shunt called the ductus venosus.
And that empties directly into the inferior vena cava and travels straight up to the right atrium. From the right atrium, the vast majority of this blood passes directly through the foramen ovale into the left atrium.
Which is just an incredible bypass mechanism. It allows the most oxygenated blood to quickly enter the left ventricle and get pumped out into the aorta to supply the developing brain.
But we have to account for the blood that doesn't make it through that foramen ovale. The remainder of the blood goes into the right ventricle and gets pumped out into the pulmonary trunk.
But remember the mechanical state of the fetus. The unexpanded fetal lungs present a very high resistance to blood flow. They're essentially collapsed and filled with fluid.
Right, and because of this high resistance, the blood in the pulmonary trunk takes the path of least resistance. It shunts straight down the ductus arteriosus directly into the descending aorta.
This brings us to the moment of birth, which triggers an incredible mechanical cascade. When the baby takes its very first breath, the lungs physically inflate.
This abruptly and dramatically lowers the pulmonary vascular resistance. Because the resistance drops, blood flow through the pulmonary artery into the lungs suddenly increases.
And this massive volume of newly oxygenated blood returning from the lungs causes the pressure in the left atrium to spike.
That pressure spike is the defining mechanical event. Basically, it acts like a one-way flap valve. The high pressure in the left atrium physically pushes the flexible septum primum against the rigid septum secundum, slamming the foramen ovale shut instantly.
Over the next few hours to days, the ductus arteriosus obliterates due to changes in oxygen tension and prostaglandins.
Finally, the physical surgical ligation of the umbilical cord causes the thrombosis and eventual obliteration of the umbilical artery, the umbilical vein, and the ductus venosus.
It's a total remapping of the cardiovascular plumbing in a matter of seconds. Let's stick with the heart for our next question regarding congenital anomalies. What are the specific components of Fallot's tetralogy, and how does coarctation of the aorta present on a chest X-ray?
Fallot's tetralogy is a classic MRCS topic. It consists of 4 distinct anatomical components that all stem from a single embryological error, the anterosuperior displacement of the infundibular septum.
Number 1, you have a ventricular septal defect, or VSD.
2, you have a stenosed pulmonary outflow tract. 3, you have a wide overriding aorta that sits directly above that VSD, receiving blood from both the right and left ventricles.
And 4, right ventricular hypertrophy, which develops as the right ventricle pumps against that pulmonary stenosis.
Exactly. Because there is a right-to-left shunt across the VSD, you see clinical cyanosis, and the severity of that cyanosis is dictated entirely by how severely obstructed the pulmonary outflow tract is.
Let's break down coarctation of the aorta next. Coarctation is essentially an abnormality in the exact obliterative process we just discussed, the process that normally closes the ductus arteriosus.
Clinically, it presents with a distinct pressure differential. You get hypertension in the upper body, but weak, delayed femoral pulses in the lower body.
To bypass this tight narrowing in the aorta, the body develops extensive collateral vessels over time. Blood flows from the costocervical trunk of the subclavian artery, routes into the superior intercostal artery, and then feeds retrograde into the aortic intercostal arteries below the narrowing.
That retrograde flow is exactly what gives us our classic X-ray finding. Because of this heavily increased high-pressure flow, these collateral intercostal arteries dilate massively and become incredibly tortuous.
On a chest X-ray, this dilated collateral flow literally erodes the lower borders of the ribs over time. This presents as distinct rib notching, a vital diagnostic clue.
That perfectly sets up Section 2, the thoracic wall, pleura, and trauma procedures. Let's pose the question, what is the specific anatomy of a typical intercostal space, and exactly how does this anatomy dictate safe chest drain insertion?
To visualize a typical intercostal space, think of it as having 3 distinct muscle layers, somewhat comparable to the layers of the abdominal wall.
From superficial to deep, you have the external intercostal muscle, the internal intercostal muscle, and the innermost intercostal muscle.
And the critical target to avoid here is the neurovascular bundle. This bundle consists of the intercostal vein, artery, and nerve. You'll often hear this remembered by the mnemonic VAN, arranged from superior to inferior.
This neurovascular bundle lies sandwiched right between the internal intercostal and the innermost intercostal muscle layers. But spatial positioning is everything here.
The vein and the artery run directly in the subcostal groove, which is tucked right on the undersurface of the corresponding upper rib.
Which is exactly why technique matters so much in trauma. When you insert a chest drain, you are taught to pass the needle or the tube close to the upper border of the lower rib, meaning the rib below the space you are targeting.
If you aim right in the middle of the space, or worse, if you hug the bottom edge of the upper rib, you are going to hit that neurovascular bundle. Lacerating that intercostal artery can cause a massive, life-threatening hemothorax.
Let's apply this regional anatomy to blunt trauma. Here is the question. What underlying abdominal organs are at risk during specific lower rib fractures?
You have to visualize the dome of the diaphragm and the anatomy sitting right beneath it. The thoracic cage protects much more than just the lungs.
If a patient sustains fractures to their left lower ribs, specifically the 9th, 10th, and 11th ribs, the underlying structure most immediately at risk of severe trauma is the spleen.
And on the flip side, if the patient sustains blunt force fractures to the right lower ribs, you must absolutely suspect and rule out traumatic laceration to the right lobe of the liver.
The liver sits high up under that right hemodiaphragm, right in the line of fire of those lower ribs.
Staying with the boundaries of the thoracic cavity, let's look at the pleura. Where do the exact boundaries of the pleura lie, and what surgical pitfalls arise from these specific borders?
The pleura has some very specific boundaries that MRCS candidates simply must memorize. Let's start superiorly. The cervical pleura doesn't just stop flat at the level of the first rib.
Instead, it follows a curved, domed line, and its apex actually extends about 2.5 centimeters above the clavicle right into the root of the neck.
This creates a major surgical pitfall. Because this pleural dome rises above the clavicle, it can be inadvertently punctured during the insertion of a subclavian or internal jugular central venous line, causing an iatrogenic pneumothorax.
The lower boundaries are just as critical. Posteriorly, and the lower limit of the pleura actually descends below the medial extremity of the 12th rib.
This is an absolutely crucial anatomical relationship for urology and general surgery residents to understand. If you are performing a posterior open loin approach to the kidney or the adrenal gland, and your dissection takes you near the bed of the 12th rib, you can easily slice open the pleura by mistake.
Again, resulting in an inadvertent pneumothorax during an abdominal or retroperitoneal case. Let's shift our focus inward to section 3, the respiratory tract and tracheostomy anatomy.
We will start with a question about the airways themselves. What are the anatomical differences between the right and left main bronchi, and what is the clinical relevance of this architecture?
The trachea terminates at the angle of Louis and divides into the right and left main bronchi, but they are structurally very different. The right main bronchus is wider, it is shorter, measuring only about 2.5 centimeters long, and it takes a much more vertical path down into the lung.
The left main bronchus, on the other hand, is narrower. It is longer, about 5 centimeters long, and it takes a much more horizontal path as it passes below the aortic arch.
This means the right main bronchus is practically a straight shot down from the trachea. Because it is wider and more vertical, aspirated foreign bodies, whether that's a tooth, food, or a small toy in a pediatric patient, are far more likely to lodge in the right bronchial tree.
Another vital clinical point regarding the bronchi involves the carina, which is that internal keel-like cartilaginous angle between the two main bronchi.
That's a highly testable landmark. If you are performing a bronchoscopy and you notice that the carina is distorted, widened, or flattened, this is a major red flag.
It usually indicates that the tracheobronchial lymph nodes sitting right at that bifurcation are massively enlarged, which is most often due to metastatic spread from an underlying bronchogenic carcinoma.
Let's move to one of the most common and critical surgical procedures for the airway. The question is, walk through the anatomical layers and potential bleeding hazards encountered during a surgical tracheostomy.
A tracheostomy requires precise midline navigation. You can use a vertical incision or a transverse cosmetic skin crease incision. If you use the transverse incision, you will almost immediately encounter the platysma muscle in the lateral parts of the wound.
Once you are through the skin, superficial fascia, and platysma, you must longitudinally split the investing layer of deep cervical fascia and the pretracheal fascia.
At this point, you retract the strap muscles laterally. This exposes the isthmus of the thyroid gland, which typically lies directly over the second, third, and fourth tracheal rings.
Depending on the patient's specific anatomy, this thyroid isthmus is either retracted forcefully upwards or it is clamped, divided, and ligated to expose the bare trachea beneath.
But the major MRCS focus here is on the specific bleeding hazards. These hazards sit right in your anterior relations as you dissect down. Superficially, you might hit the venous anastomosis between the anterior jugular veins as they cross the midline.
Deeper down, you have the inferior thyroid veins forming a plexus. You also have to watch out for an occasional anatomical variant called the thyroidea ema artery, which runs straight up the midline of the trachea.
Furthermore, pediatric anatomy changes the risk profile. If you are performing this procedure on a young child, the brachiocephalic artery, the left brachiocephalic vein, and the thymus gland might be located very high up in the neck.
This makes these major vascular structures apparent and highly vulnerable in the lower part of your surgical incision. Excellent breakdown. This takes us right into section 4, the diaphragm and referred pain mechanisms.
Let's pose the embryology question first. What are the 4 embryological components of the diaphragm, and what specific clinical defects result from a failure of fusion?
The diaphragm is an intricate composite structure formed from 4 distinct embryonic parts merging together. First, you have the septum transversum, which grows posteriorly from the ventral body wall and eventually forms the tough, fibrous central tendon.
Second, you have the mesentery of the foregut, which forms the crura and the median muscular part adjacent to the vertebral column.
Third, there is a muscular ingrowth from the lateral body wall itself. And fourth, you have the pleuroperitoneal membrane, which is a small dorsal component that closes the primitive communications between the pleural and peritoneal cavities.
Think of it like stitching together a complex tent from 4 different pieces of canvas. So what happens when these specific seams fail to fuse properly?
You get congenital diaphragmatic hernias, and the exact type depends entirely on which piece of the canvas failed to close. If the pleuroperitoneal membrane fails to close, you get a posterolateral hernia, classically known as a Bachdelic hernia.
Due to the presence of the liver on the right, this failure is much more common on the left side, allowing abdominal contents to herniate up into the chest and impair lung development.
Alternatively, if there is a fusion defect anteriorly, right between the xiphoid process and the costal origins of the diaphragm, you get a Morgagni hernia.
Moving from the embryological seams to the actual adult anatomical openings. The question is, at what specific vertebral levels do major structures pierce the diaphragm?
This is a classic spatial association you simply have to lock into your memory. Let's count down the thoracic spine. At the level of T8, the inferior vena cava and the right phrenic nerve pass through the central tendon of the diaphragm.
Moving down to T10, the esophagus and the anterior and posterior vagus nerves pass through the muscular right crus.
And finally, at T12, the aorta, the thoracic duct, and the azygos vein pass behind the diaphragm. A helpful conceptual point here is that the aortic opening at T12 isn't strictly an opening in the diaphragm muscle itself. Rather, it's a space located behind the median arcuate ligament.
Let's tie the diaphragm to a symptom-based question. Why does diaphragmatic irritation present with two distinctly different patterns of referred pain?
It all comes down to the dual nerve supply, essentially meaning the diaphragm is wired to two different fuse boxes. The central tendon of the diaphragm receives its sensory innervation from the phrenic nerve.
The phrenic nerve arises high up in the neck from cervical roots C3, C4, and C5. If you have chemical irritation of the central diaphragm, say, from free blood in the abdomen pooling under the diaphragm after a ruptured spleen, that pain signal travels all the way up the phrenic nerve.
It enters the spinal cord at the C4 level and refers pain to the corresponding C4 dermatome on the skin. This presents clinically as severe shoulder tip pain, known as Kehr's sign.
But the periphery of the diaphragm is wired completely differently. The peripheral muscular part of the diaphragm, along with the adjacent parietal pleura, is innervated by the lower 6 intercostal nerves.
If an inflammatory process irritates this specific peripheral area, for instance, a severe right lobar pneumonia sitting on the diaphragm, the somatic pain signals travel via those lower intercostal nerves.
These nerves terminate in the lower abdominal wall. Therefore, a lung infection can literally refer pain to the right iliac fossa, incredibly closely mimicking the presentation of acute appendicitis.
That distinction between central shoulder pain and peripheral abdominal pain is a crucial diagnostic concept. Let's move to our final section, Section 5, the heart and mediastinal landmarks. Our first question here is about blood supply.
What exactly defines coronary codominance, and what is the precise anatomical mechanism of referred cardiac pain?
Coronary dominance is a term that confuses many, but it is entirely defined by one specific vessel. Whichever artery supplies the posterior interventricular artery, which is also called the posterior descending artery.
In the vast majority of patients, this posterior vessel is a branch of the right coronary artery, making them right dominant. However, in about 10% of the population, the posterior interventricular artery branches off the circumflex artery, making those patients left dominant.
In another 10%, both the right coronary artery and the circumflex artery contribute equally to the posterior interventricular artery. That shared supply is the definition of codominance.
And regarding cardiac pain, how does ischemia in the myocardium cause a patient to feel crushing pain in their arm or their jaw?
Cardiac pain is referred to the body surface areas that send sensory impulses to the exact same spinal cord levels that receive the cardiac sensation. Sensory pain fibers from the heart travel through the cardiac plexus and the sympathetic chain, traveling up to the dorsal root ganglia of T1, T2, T3, and T4.
Right, and when those signals arrive, they excite the upper thoracic segments of the spinothalamic tract. The brain misinterprets this visceral signal as somatic pain originating from the corresponding T1 to T4 dermatomes.
That maps exactly to the anterior chest wall and the inner medial aspect of the left arm.
And the jaw pain follows a different route. That happens because cardiac vagal afferent fibers carry ischemic signals up to synapse in the nucleus of the tractus solitarius in the medulla of the brainstem.
From there, signals descend to excite upper cervical spinothalamic tract cells. That specific higher-level innervation pathway refers the severe ischemic pain directly to the neck and the lower jaw.
Beautifully mapped out. Let's close with our final anatomical question for this revision session. Why is the angle of Lewy considered the single most important horizontal landmark in the thorax for MRCS candidates?
The angle of Louis, which is the manubriosternal junction, is essentially the master key for thoracic anatomy because it corresponds perfectly to the horizontal plane of the lower border of the T4 vertebra.
At this exact transverse T4 plane, an incredible number of critical anatomical transitions occur simultaneously.
I'll start the list. First, it marks the articulation of the second costal cartilage with the sternum, which is how we count ribs. Second, it is the exact level where the trachea bifurcates into the right and left main bronchi. Third, it represents both the commencement and the termination of the arch of the aorta.
I will finish the list. Fourth, this imaginary plane forms the anatomical dividing line, separating the superior mediastinum above from the inferior mediastinum below.
Fifth, it is the exact level where the azygos vein arches anteriorly over the root of the right lung to empty into the superior vena cava.
And finally, it is the horizontal plane where the ligamentum arteriosum is located. If you are visualizing a cross-section of the chest, the T4 plane is the busiest intersection you will find.
That wraps up today's rapid-fire revision deep dive. We covered immense ground, from the asymmetrical looping of the recurrent laryngeal nerve to the dual fuse box of the diaphragm's referred pain. Thank you so much for tuning in.
Remember, hit that follow button right now, rate the show if this helped clarify your spatial anatomy, and head directly to www.medsynckltd.com to get your surgical simulation kit, complete with a suturing kit and microsuturing instruments.
We want to hear from you. Please leave a comment or a question down below about the specific surgical anatomy we reviewed today.
And before you get back to your revision, we want to leave you with a final concept to mull over on your own. We've spent this session detailing how anatomical quirks, like the steep vertical angle of the right main bronchus and the recurrent laryngeal nerve's bizarre embryological path, create highly specific vulnerabilities during surgery.
Consider how the evolutionary shift to upright bipedalism and our reliance on abdominal breathing mechanics may have introduced other distinct, uniquely human mechanical vulnerabilities in the torso that modern surgeons must now navigate.
See you next time.